Ovarian cancer.
Summary of ovarian cancer. Ovarian cancer is a disease that arises in the ovaries, the female reproductive organ responsible for making eggs and hormones. Often referred to as the silent killer because symptoms usually go unnoticed or get ignored and can mimic other less severe conditions, leading to late-stage diagnosis. Typically, it affects women over the age of 50, although it can occur at any age. Risk factors include a family history of ovarian or breast cancer, inherited genetic mutations in one's DNA, and certain lifestyle factors like obesity and smoking, which can all lead to ovarian cancer. Treatment options depend on the stage and type of ovarian cancer, but it may include surgery, chemotherapy, and targeted therapy. Early detection is challenging due to the lack of specific symptoms and reliable screening tests, emphasizing the importance of awareness and understanding of potential risk factors.
Normal versus cancerous cell division. How a normal cell divides. The cell will go through a process called cell division to make an identical copy of itself. This process includes interphase, which is organelle duplication, mitosis, which is chromosome duplication, and cytokinesis, which is total cell division. As demonstrated in the diagram, any mutated cells will go through apoptosis and commit cell suicide to prevent from any dangerous or harmful cells from harming the body. A type of gene called tumor suppressor genes will limit the amount of cell division in a certain part of the body. If this cell were to be mutated, the cells would divide uncontrollably, causing blood clots or other diseases. Oncogenes are mutated proto-oncogenes that cause cells to divide faster. This is how a cancer cell divides. They also go through the same steps of cell division, but this time they resist apoptosis and manage to stay alive while being mutated. As they multiply more, they can contract more and more mutations. So the first time might have one mutation, and the second time it might add one. If the oncogenes or tumor suppressor genes are affected, the mutated cell could gain certain advantages when competing with other cells. They go through the same stages and processes as normal cells. However, with new mutations, like the resistance toward tumor suppressor genes, they can commit acts that intervene with the other processes in the body. They can multiply out of control, causing blood clots and cutting off circulation within one's body.
Genes and mutations in ovarian cancer. The missense mutation in the TP53 gene, Y220C, tyrosine replaced by cytosine at amino acid 220. The missense mutation in the TP53 gene, R175H, arginine was replaced by histidine at amino acid 175. Missense mutation in Notch2 gene, G978R, glycine was replaced with arginine at amino acid 978. And then missense mutation in the LAPS1 gene, H820R, histidine was replaced with arginine at amino acid 820.
Gene functions and mutations. The top 3 genes in ovarian cancer are TP53, Notch2, and LATS1. TP53 makes the protein called p53, which keeps cells from dividing too fast, acting as a tumor suppressor. When the DNA in the cell gets damaged, this protein helps decide if the DNA should be repaired or if the cell should undergo apoptosis. But when it's mutated, it will let cells with damaged DNA get through checkpoints, leading to uncontrolled cell division. Notch2 is a gene that makes a receptor, and this receptor sends signals that will help with the body's function and development. It is helpful for growing cells for an embryo, and after birth, it helps with the immune system and tissue repair. But when it's mutated, it will accelerate cell growth and division, acting as an oncogene. The third gene is LATS1, and this makes a tumor suppressor, and a negative regulator of CDC2 cyclin A. And this cannot stop cell division of cancer cells when it's mutated. On the right is the genes in the cell cycle. So at the first checkpoint, p53 will decide if the damaged DNA should be fixed or if the cell should kill itself. and LATS1 will act as a tumor suppressor as well. Throughout interphase, the Notch2 receptor will stimulate growth. At the G2 checkpoint, P53 will again decide if the DNA should be repaired or the cell should undergo apoptosis. The LATS1 gene will downregulate CDK1 kinase activity. And at the mitosis checkpoint, this gene will phosphorylate a transcription promoter gene, and by doing that, the LATS1 regulates genes for cell proliferation and death.
The risk factors of ovarian cancer. Old age. Women ages 24 to 30 have a 4% chance of developing ovarian cancer, while women ages 55 to 64 have a 24% chance of developing ovarian cancer. Environmental and lifestyle factors. The exposure to environmental agents such as pesticides, herbicides, and talc have shown to increase the risk of ovarian cancer, though studies about this are limited. Smoking, obesity, and diet may also increase the risk of developing ovarian cancer. Genetic mutations and family history. Ovarian cancer can be detected in genes by looking at the BRCA1 or BRCA2 genes. 65 to 85% of women who have ovarian cancer have mutation in these genes. Lynch syndrome. Lynch syndrome affects the process of fixing mistakes made when DNA gets copied. It occurs when there's a germline mutation in the genes MLH1, MSH2, MSH6, BMS2, and EpCAM. It normally prevents cancers or lowers the risk for cancer, but with a mutation, it prevents them from being able to work properly. Hormone replacement therapy. Women who take estrogen after menopause are more likely to develop ovarian cancer. Endometriosis and menstruation factors. Endometriosis is where the tissue of the uterine lining starts to grow outside of the uterus. This causes very painful periods and can affect a woman's ability to get pregnant. This could lead to an increase of ovarian cancer because of the endometriotic cysts. They produce a fluid which increases oxidative stress, which could cause genetic mutations or the violent making of ovarian cysts.
Global distribution. So all this data is from 2020, and it's data for incidences of ovarian cancer or people with ovarian cancer, but it's not for mortality. The most frequent incidences are in Central and Eastern Europe with an ASR of 10.7. Second is Northern Europe with an ASR of 8.8, which is also tied with Polynesia, which has an ASR of 8.8. North America has an ASR of 8.1, and in fifth place, Southeast Asia with an ASR of 8.1. Income-related rates. So basically, in high-income countries with has an ASR of 8.0, which shows that high-income countries have the most frequent ovarian cancer. Upper middle income countries have an ASR of 6.3. Low middle income countries have an ASR of 6.1, and low income countries have the least ASR, showing that high income countries have the most chance of people with ovarian cancer. The rates are higher in more developed countries because of lifestyle cancer factors associated with them, such as smoking, obesity, diet, and industrial exposures.
Symptoms. Ovarian cancer can be asymptomatic, meaning one could contract this type of cancer and feel no symptoms until the later, more severe stages. Some symptoms could include pelvic pain. Women with ovarian cancer may experience pelvic pain that feels like pressure or discomfort, which may be constant or intermittent. Changes in bathroom habits. Ovarian cancer could lead to changes in urinary habits, such as increased frequency or urgency, or bowel habits, such as constipation or diarrhea, without any apparent cause. Feeling full quickly. Women with ovarian cancer may feel full quickly, even after eating small amounts, which can be a result of the tumor affecting the digestive system or causing fluid buildup in the abdomen. Abdominal bloating. Ovarian cancer can cause persistent and unexplained swelling or bloating in the abdomen, often accompanied by a feeling of fullness or discomfort.
Screening for ovarian cancer. Transvaginal sonogram, or also called an ultrasound. It consists of using sound waves to check for any growth in the pelvic area. This method will lead to additional testing to see what the growth is. Blood test. It looks for CA-125, a substance which is a tumor marker and is found in the blood and urine of a woman who has ovarian cancer. This test isn't the best way because certain medical conditions or circumstances, such as pregnancy, menstruation, peritonitis, and others, can increase CA-125. Biopsy, often resulting from an ultrasound or a blood test. These tests often detect that there is an unknown object or growth in the pelvic area. A biopsy will remove some of the fluid or some tissue in the pelvic area and look for cancer cells. Genetic screening. When you get genetic screening for ovarian cancer, it looks for BRCA1 and BRCA2 genes. Doctors usually use a multi-gene panel because it can look at multiple genetic mutations at the same time. They check these genes because they are usually the ones that protect against ovarian cancer, but a mutation in them could lead to them not working as they should.
For treatment options, one option is surgery. In surgery, you can do staging. So you need cancer to be staged so that they can decide on the best treatment. Uterus, both ovaries, and fallopian tubes are removed during staging. The omentum is removed. Lymph nodes and fluids in the pelvis or abdominal cavity is taken out for a biopsy, and tissues and fluids is sent to a lab to look for cancer cells. Intraoperative imaging to find tumors not seen or felt by doctors, to inject fluorescent Cytolux drug into blood. Cytolux attaches to proteins in ovarian cancer cells. Imaging systems make the drug light up, indicating presence of ovarian cancer cells. Debulking. Optimally debulk. Tumors that are larger than 1 centimeter are removed. Suboptimally debulked, and then that tumors bigger than 1 centimeter are left inside. A piece of colon might be removed and sewn back together. Small intestine, bladder, stomach, and other organs might also need to be removed. And you can get pregnant. They'll go into menopause if uterus and ovaries are removed.
Chemotherapy. The usual combination that doctors give is a platinum compound and a taxane. Platinum compounds bind and cross-link DNA that controls cellular activity. This causes the cell to die before it grows, probably in early interphase. Taxanes are drugs that target microtubules like spindle fibers, and so they can't organize in prophase. Then the chromosomes can't line up for metaphase, and the cell can't divide. IP chemo is for stage 3, and if the patient has been optimally debulked. Cisplatin and paclitaxel is injected through a catheter, which is connected to a port, and then the needle is placed into the port, and this method gives the most concentrated dose of drugs. Targeted therapies. Avastin is a drug that blocks the growth factor, VEGF, which helps cancer cells form blood vessels that help them grow, and this would be able to kill cells in G1. Another targeted therapy is drugs that target folate receptor alpha, and this receptor is found on a lot of ovarian cancer cells. So basically an antibody drug conjugate will attach to this receptor and bring chemo drugs directly to the cell. Another targeted therapy is a PARP inhibitor. PARP enzymes help repair damaged DNA in the cell, and the BRCA gene mutation will make it hard for a cell to repair DNA. PARP inhibitors will make it even harder, pushing the cell to death. PARP inhibitors would act throughout interphase checkpoints, so that when a cell decides between repairing DNA and apoptosis, it won't repair the DNA because of the inhibitor, so the cancer cell dies. And here is a PARP inhibitor video.
As the name already suggests, PARP inhibitors inhibit PARP. But what is PARP? PARP is short for poly-ADP ribose polymerase, and those enzymes belong to a protein family whose members are involved in DNA repair. PARP proteins detect DNA damage in form of single-strand breaks. Once PARP has bound to the DNA, it changes its structure and begins to synthesize a chain of polymeric ADP ribose, short PAR. This molecule signals the recruitment of DNA repair proteins. The members of this DNA repair machinery can successfully repair the single-strand break. As we have seen, PARP is an extremely important player to prevent damage in a normal cell. In cancer cells, however, DNA damage might be exploited. Now we can take a look at the PARP inhibitors which inhibit the DNA damage repair. Inside the therapeutics are molecules that are referred to as PARP inhibitors. Those will bind to PARP and block the catalytic action of the DNA repair enzyme. In this case, PARP can not synthesize PAR, and thus the DNA single-strand break repair proteins are not recruited. The single-strand break remains. During replication, the single-strand break can result in a more severe DNA double-strand break. In normal cells, double-strand breaks can be repaired by mechanisms such as homologous recombination. Tumor cells, however, often harbor numerous mutations causing a defective double-strand break repair. If this double-strand break remains unrepaired, and this is especially the case in patients with a BRCA1 mutation, it is likely to cause genomic instability, and this can end up in apoptosis. In brief, the aim of the PARP inhibitor as an effective therapeutic is to eliminate cancer cells or at least make them more sensitive to other treatments in combination with radiation or chemotherapy.
Clinical trials. Niraparib study with placebo. To look at the effectiveness of niraparib in stage 3 or 4 of ovarian cancer. 733 older women that have completed platinum-based chemo with a response were treated. They were randomly given niraparib or placebo, a drug with no effect. Those who were given niraparib had longer progression-free survival than those given placebo. They survived longer in general, and they had worse symptom experiences. Olaparib study. Goal is to estimate progression-free survival, how long someone lives with the disease and doesn't get worse. Also to describe treatment patterns. Participants were 350 older women with advanced ovarian or fallopian tube cancer who already did platinum-based chemo.